Now let's move on to fracture. What is a fracture? A fracture is a break in the continuity of the bone, or the break in the continuity of the cortex. So this is a bone, and if there is a break in the cortex here, we call it a fracture. Okay. Now for the symbol we use hash. Okay, hash is the symbol that we use to describe fracture. So this is how I will probably sometimes write it, although I have tried not to. And when the orthopedic surgeons are usually writing notes, you will see this symbol. So don't immediately think it's a hashtag for something. It's a fracture sign. Anyways, so it's a break in the continuity of the cortex. So it's a break in the continuity of the cortex of the bone. Now, how will you make the diagnosis of a fracture? It's very simple. It's a clinical diagnosis or a radiological diagnosis. Now, radiological diagnosis does not take rocket science. You will see an X-ray and you will see a break in the bone and you have made your diagnosis. But what is important is to make the diagnosis before the radiologist does. Right? So how do you make the diagnosis clinically? What is the pathognomic sign of a fracture? Think about it. Pathognomic sign means the moment you see it, you know that it is a fracture and nothing else. The pathognomic sign of the fracture is abnormal mobility. Now let me explain what this is. Normally, your body is supposed to move at the joints. For example, your upper limb is supposed to move at the shoulder or the elbow. It is not supposed to move right here in the middle. If it moves here right in the middle, what does it imply? It's not a superpower. It implies there is a fracture here. There is a discontinuity in the bone because of which it is moving here. Okay, so loss or abnormal mobility. Abnormal mobility is a pathognomic sign of a fracture. Now, in olden days, crepitus was considered as the pathognomic sign. What is crepitus? Suppose this is the bone, fractured, bone, fractured. Now, when the bone is fractured, there are ends at the bone which are serrated and serrated like this. Now, when you rub against each other, you will feel crepitations. This is known as crepitus of a fracture. Obviously, in 21st century, this is not something that we recommend doing, because to make a diagnosis of a fracture, abnormal mobility is enough. X-ray is more than enough. Right? X-ray is more than enough. You wouldn't want to go to the patient and be like, "Bhaiya, wait. Give me your leg. Let me move it and see if you have a fracture or not." It's very painful. Nobody does it. Okay, it's only historical. Crepitus. Okay. In your exam, if abnormal mobility is not there for the pathognomic sign, then you can mark crepitus. Otherwise, stay away. Now, there are certain fractures that can be incomplete. Not all fractures will go through and through. We will have stress fractures. We will have green streak fractures. We'll talk about so many other fractures. In those fractures, you will not get abnormal mobility because the bone still is in continuity. Only a part of it is broken. So if I ask you, or someone asks you, what is the most consistent sign of a fracture? It means a sign that is seen in each and every type of a fracture. It is tenderness, because whenever there is a breach in the cortex, whether it is complete or incomplete, when you press on it, it will be painful. Okay? So far so good, you've understood. Now, what are the causes of fracture? Obviously, trauma is one major and the most important and the most common cause. There are causes other than trauma also. What are those? Stress fractures and pathological fractures. Let's club them in fractures that occur because of insignificant trauma. A significant trauma is someone hitting you very hardly with a bat. That is a significant trauma that is more likely to cause a fracture. Insignificant trauma means daily activities, running and jogging, these kind of activities. Or, just falling from a chair, falling from a stool, falling from a bed. Trivial trauma. These are all insignificant traumas. We'll talk about in detail later. But let's understand traumatic fractures first. What are the various types? Now, there are so many types, but these are a few common ones that I would want to discuss. What you'll notice, this is the tibia, and you're noticing that there is a fracture going like this, which is perpendicular to the long axis of the bone. This is known as a transverse fracture. This is known as a transverse fracture. Again, everything is written. Whatever I'm speaking is written, just bear with me. Transverse fracture. Now, what is the force that causes transverse fracture? A force that is known as the tension force. What is the tension force? A tension force is a force which pulls the bone away. Okay, suppose this side is being pulled by something, this side is being pulled by something, you'll get a transverse fracture right in the middle. Or another mechanism is direct trauma. Somebody hits you with a bat directly. So direct trauma or tension force gives you transverse fracture. Everything written. Listen, only listen. Then there is this fracture which gives you a diagonal line. This is known as an oblique fracture. Oblique fracture. Now, oblique fracture, what is the mechanism? Oblique fracture mechanism is compression force. There is something compressing from the proximal as well as distal end. Something compressing like this the bone will crack in an oblique fashion. Everything is there. Just listen. Then there is something known as a spiral fracture. Spiral fracture. Fracture line goes in a spiral. This is because of a twisting injury to the bone. Twisting force gives you spiral fracture. Then there is comminuted fracture. Comminuted fracture. What do you mean comminuted fracture? Comminuted fracture means multiple fragments, multi-fragmentary fracture. Okay, it has crushed multiple fractures. Okay, this occurs because of direct trauma or crush injury. Then there is something known as segmental fracture. Segmental fracture is when the bone has two fractures and the bone is divided into segments. So this is one segment, this is one segment, this is another segment. Segmental fracture. Okay, these are just the names. So let me show you now. This is a transverse fracture. What is the force? Tension force or direct trauma. Then there is oblique fracture. What is the force? Compression force or also direct trauma. Then there is a spiral fracture. What is the force? Twisting force. Twisting. And then there is something known as a butterfly fragment fracture. What is the butterfly fragment fracture? When you bend the bone. When you bend the bone, what will happen? It will assume a butterfly fragment. This fragment of the bone is considered as the butterfly fragment. Okay, this is considered a butterfly fragment. Again with the forces, oblique force is compression force, oblique fracture is compression force, transverse fracture is tension force or distractive force, butterfly fracture is bending force, and spiral fracture is twisting force. As promised, everything is written. Transverse fracture, line is transferred to the long axis of the bone, direct trauma or force from opposite directions of the bone known as tension force. Oblique fracture, compression force, spiral fracture, twisting force, butterfly fragment seen in bending force, comminuted fractures, direct trauma, segmental fracture where there are two fragments, two transverse fractures that divide the bone into multiple segments. Okay, everything is written. These are your types of fractures that occur because of trauma. Now, one interesting pattern of fracture is known as avulsion fracture. Again, it is there. Listen to me. What is avulsion fracture? Means a bone has muscles attached through a tendon. So when the muscle pulls, the tendon pulls, and the tendon pulls away a piece of bone with it. That bone moving away from the original bone is a fracture known as avulsion fracture. Now this typically occurs on bones which has strong muscular attachments. One very common example is patella. So look at this. Patella has quadriceps attachment. And when this quadriceps pulls, it will cause transverse fracture of the patella and the fragments move away. This is avulsion fracture. Another example is olecranon. If you recall, say this is your olecranon. This is the humerus. Which muscle comes and inserts here at the tip of the olecranon? Here, which muscle comes and inserts there? Let me give you an example. Let me give you a hint. Quadriceps, hamstring, gastrocnemius, triceps. Triceps, excellent. Triceps comes and inserts here, and whenever there is a strong pull of triceps, what will happen? There will be a fracture. This is known as avulsion fracture. So patella fracture and olecranon fracture are classical examples of avulsion fracture. Okay, we are understanding the fracture patterns. We'll discuss the treatments later on. Okay, so these are the fracture patterns because of strong force. Now moving on to fractures that occur because of insignificant trauma. Now what are the fractures that occur because of insignificant trauma? These are your pathological fractures and stress fractures. Now, if you are not focused, you might confuse them. So let me give you a clear distinction of what they are. A pathological fracture occurs in an abnormal bone. There is a pathology in the bone that makes the bone weak, and when you apply force or the normal force to the bone, it breaks. Okay? So abnormal bone, normal force. Think pathological fracture. On the other hand, what is stress fracture? It is a normal bone but abnormal force. Okay, it's a normal bone but abnormal force. Let me give you a clinical perspective here. Stress fracture is a fracture that occurs in a normal bone when you apply abnormal force to it. What do you mean abnormal force? Abnormal force means repetitive abnormal loading. Repetitive abnormal loading of the bone. Okay, suppose you are an intern and you are asked to run around collecting blood samples. Okay, you are not used to that kind of activity. Suddenly you have increased the intensity and frequency of this activity, repetitively, abnormally loading your bones. Your bones will go into stress fracture. Remember I told you, your bones are basically designed based on the requirement. If you're an active individual, if you're a healthy, active athlete, your bone density will be more and your chances of stress fracture would be less. But if you're a normal individual and suddenly starting an activity like an athlete, you will get stress fracture. Now, pathological fracture, what will be the story? The story will be there is a disease or pathology in the bone that is making the bone weak. And when this weak bone is exposed to normal forces, it will break. That is pathological fracture. So, bone is rendered weak due to a disease process, and on application of normal force, it breaks. Okay, are you understanding the clear distinction of pathological and stress fracture? Okay, now let's start to read pathological fracture first. Pathological fractures can occur because of localized pathologies or generalized pathologies. Now, what are localized pathologies? That there is a specific part of the bone which has a pathology in it. Like, for example, there is a tumor, there is a cyst, there is a lesion, there is ischemia, there is an infection. This is the list. That part of the bone will be weak and that part of the bone will break. Now, what is generalized cause? Generalized cause, the bones are weak generally because of some underlying metabolic bone disease. What could it be? It could be rickets, osteomalacia, osteoporosis, metastasis, osteogenesis imperfecta, osteopetrosis, so many. The most common ones are osteoporosis and metastasis. Osteoporosis more common than metastasis. Okay, so osteoporosis and metastasis. But here I want to tell you that the term pathological fracture is usually reserved for metastasis, whereas osteoporosis is assumed to be something that will occur in every elderly person. They call it the fragility fracture. But for all intents and purposes, for our exams in India, let's assume osteoporosis is the most common cause. But please keep that in mind. Pathological fracture in the Western literature is usually reserved for metastasis. So this disease makes the bone weak and hence the bone will break. Pathological fracture. Now, while we are talking about pathological fracture, what do I want you to remember? That the patient will complain to you of pain in the bone. And usually this pain happens before the fracture. Why? Because there is pathology in the bone and the bone is weak. And when this individual is putting weight on that bone, this weak bone will start to break, will give you micro fractures. And these micro fractures will cause pain. They will not be visible on X-ray, but they will cause pain. And only after a very long time, the complete bone breakdown will happen, which will give you the pathological fracture. So pain will precede the fracture. This is very, very important point. Okay. Now, when you do an X-ray, you will find a lesion. Suppose a patient comes to you with pain. You get an X-ray done. And on X-ray, you find a lesion in the bone, which is not fractured yet. Because there is a localized pathology, you get a lesion in the bone. What will you do now? Will you wait for it to fracture or will you intervene prophylactically to prevent its fracture? Now we have a criteria for it. We'll talk about that in a minute. But the points that I've already mentioned. Pathological fracture classically complains of pain before the fracture. Their complaints are usually pain. Get an X-ray done, and on X-ray usually you will find a lesion. So look at this. There is a lesion in the humerus here. Can you see the lesion here? Again, can you see a lesion here in the humerus? And you can see there is a fracture because of the lesion. These are pathological fractures. Now, for example, patient comes to you with pain. You get an X-ray done. There is a lesion in the bone, but yet not fractured, which means it's an impending pathological fracture waiting to happen. Now, your aim is to either protect it or wait and watch. How will you make that call? With a criteria known as Merrill's criteria. Now, you don't have to remember the whole criteria. Just remember that the cutoff score is considered 8. If it is more than 8, you will go and prophylactically fix it. If it is less than 8, you will wait and watch. Okay? That is what you have to do. Now, I told you the two important causes of pathological fractures are osteoporosis and metastasis. Right. Now, in osteoporosis, there are certain fractures that are more commonly seen, and in metastasis, there are certain common fractures that are seen. So, what are those fractures? In osteoporosis, the most common fractures occur in the spine, followed by hip, followed by distal end of the radis collis fractures. These are all osteoporotic fractures. So, elderly people or your grandmother or grandfather who will have osteoporosis, they will complain of back pain. Why is that they're complaining of back pain? Because their vertebral micro fractures have already started because of osteoporosis. And now because of metastasis, the fractures usually occur around the proximal femur, neck or subtrochanteric femur. Spine also, but around the proximal femur is the more common location for metastatic fracture. Look at this. There is a problem here in the subtrochanteric region giving you a fracture. This is known as banana fracture because it gives a pattern of banana fracture. This is a terminology usually reserved for a metabolic bone disease known as Paget's disease. Otherwise, subtrochanteric fractures are also very common in metastasis. Now listen to me. Whenever a patient comes to you with a lesion in the bone, you would want to rule out metastasis because it can be one isolated lesion or it can be multiple lesions. So the standard investigation that anyone would advise is FDG PET CT scan. FDG PET CT scan basically helps you pick up any other hidden metastasis in the body. Okay, it helps you evaluate the bony metastasis. FDG PET CT scan is the investigation of choice to rule out bony metastasis. So that is everything about pathological fracture. So what is the treatment? Obviously, tell me. If it's a pathological fracture, treat it with internal fixation and also treat the underlying cause. Don't forget to treat the underlying cause. If it's osteoporosis, start the patient on osteoporotic treatment, that is bisphosphonates. Okay, so far so good. Fracture, treat the underlying cause and the fracture. ये हो गया आपका osteoporosis, metastasis or any pathological fracture. Now moving on to stress fracture. What did I tell you about stress fracture already? I told you bones are normal, but because of repetitive abnormal loading of the bones break. Who are these people? These are your interns, your military recruits, your dancers. Okay, these are the people. Now dancers, military recruits, yes, you see, a dancer or a military recruit, they are well-trained people. They have good bone density. But if an event is coming along, they would train extra hard for that event. And when they would train extra hard for that event, what would happen? They would suddenly increase the intensity and frequency of that repetitive trauma to the bone. And because of that, the bones will undergo stress fracture. The classical complaint of the patient of stress fracture is pain after the activity, whereas pathological fracture was pain before the fracture or pain before the fracture. Here there is pain after the activity. Thoda socho. Now, stress fracture obviously will occur more in the upper limb bones or lower limb bones. Think hard. Everything is written, just listen. Obviously lower limb bones, because lower limb bones are the ones that are taking a lot of weight, unless you are that special person who walks with your hands, which you are not, right? So lower limb bones are affected more than upper limb bones, and usually there is a history of sudden increase in intensity or frequency of activity. You get an X-ray done. Usually the fracture, that is stress fracture, is not visible on X-ray for a few weeks. For good 2 to 3 weeks, the fracture will not be visible. It's usually a clinical diagnosis because the patient will classically have pain after activity and he can put his finger and show you where the pain is. Point tenderness. So what is the investigation of choice if the fracture is not visible on X-ray? The investigation of choice for a fracture that is not visible on X-ray or a hidden fracture or an occult fracture is MRI. Okay, MRI is the investigation of choice. X-rays are usually not positive for 2 to 3 weeks. There is a sudden increase in intensity and frequency of activity. Lower limb bones are affected, more common than the upper limb bones. Everything I've told you is written here. Okay, so in the lower limb or in the whole body, which is the most commonly affected bone by stress fracture? Tibia. Okay, tibia is the most commonly affected bone by stress fracture. But if they specifically ask you in the foot it is metatarsals. Which metatarsals? Second more than third metatarsal. And this is known as March fracture. In orthopedics, you will come across eponymous fracture. Eponymous fracture means named fractures. Whenever there is a named fracture, I will try my best to give you a background story of why it got that name. And if you remember that story, you will remember that fracture. Otherwise, there will be a good 20 to 30 named fractures and you will mishmash all of them by the end of the topics. So March fracture is seen in people who train for march past or parades. These are the people who are stamping their feet as they are training. So they'll get stress fracture of the foot. Which bones? Metatarsals. Which bones? Second more than third. Now there is a controversy here. Which part of the metatarsal? Neck or shaft? Both are correct answers. Based on the literature that I have received and read, neck is a better answer. Otherwise, both are correct answers. It's a controversial question, and this controversy is perennial. My thing with controversial questions is just memorize one answer and move out. If you get it right, great. If you don't get it right also, no problem. Look at this. Here, this is the metatarsal. First, second, there is a stress fracture of the second metatarsal. This is known as March fracture. Now, sometimes patients come to you with multiple stress fractures. In that case, the investigation of choice is bone scan and not MRI. Multiple stress fractures, bone scan picks up multiple stress fractures, and that is the investigation of choice. Now, what is the treatment of stress fracture? Because the fracture occurs of stress, rest should suffice, yes. But not only rest, you should immobilize the bone so that there should not be any movement. Rest and immobilization is the treatment of choice for stress fracture. Now, while we are on the topic of metatarsals, there is one very important metatarsal fracture that is asked on your exam. It is an eponymous fracture, means it has a name, and the name is Jones fracture. It got the name from the father of modern orthopedics, Robert Jones. Now, what is this fracture? It is a fracture that occurs at the base of the fifth metatarsal. This part. In lower limb trauma, I have discussed this, but I will just quickly put it over here so that you do not get confused. Now, the base of the fifth metatarsal, for simplicity of understanding, is divided into three parts. Zone 1, 2, 3. Zone 1, 2 and 3. Now, zone 1 fractures are pseudo-Jones fractures. They are essentially avulsion fractures. Zone 3 fractures are stress fractures. We are not worried about them because they are not very common. We are worried about the zone 2 fracture known as the Jones fracture. And the reason we are worried about it is because it's a fracture that is notorious to go into non-union. And the reason behind that is very simple. It is in a watershed area of vascularity. So the proximal part of the bone receives blood like this. The distal part of the bone receives blood like this, but the zone 2 does not get its own vascularity, so it's always compromised. So if there is a fracture here, it will usually go into non-union. That is why this is a very significant fracture for your exam. You need to remember Jones fracture. Okay. Now, how do you diagnose this? Very simple. Look at the X-ray, and on X-ray you should see the part of articulation between fourth and fifth metatarsal. So this is fourth and this is fifth, right? So they articulate here. That part of the fifth metatarsal is the zone 2. And if there is a fracture in the zone 2, it is considered as Jones fracture. Otherwise here, it's pseudo-Jones. Otherwise here, stress fracture. ठीक है? समझ आ गया? Jones fracture. Just because we were talking about metatarsal. Nothing to do with stress. Now coming back to stress and its injuries. Another injury that occurs in stress is shin splints and runner's fracture. What is a runner's fracture? Very simple. It's a stress fracture seen in runners, marathon runners. Okay. What is it? It's a stress fracture of the fibula. If you look carefully, this is a fracture here in the fibula. This is known as a runner's fracture. Eponymous fracture, named fracture. Remember the name? Runner. Where did it get the name from? Seen in runners. So base of the fibula or lower end of the fibula, stress fracture. Now what are shin splints? Shin splints are pain in the shin. What is the shin? Anteromedial aspect of your leg. Okay, the hard part of your leg. That is known as shin. See, in people who are marathon runners or trekkers, what happens? The constant contracture of the muscle causes periostitis or insertional tendinitis. Mostly periostitis. Periosteum is attached to the bone. Muscles are over the periosteum. Muscles get inflamed. They inflame the periosteum. So this is periostitis. It causes pain on the anteromedial aspect of the leg in runners or in trekkers. This is known as medial tibial stress syndrome. Obviously, because it is a periostitis and not a fracture, will you see any fracture on X-ray? No fracture on X-ray. No fracture on X-ray. Now, why is shin splints important? Because shin splints was asked as an MCQ on your exam, and the patient had pain on the anteromedial aspect of the leg. A marathon runner, a person who is active, complaining of pain on the anteromedial aspect of the leg. What if there is another athlete who complains of pain on the posterior aspect of the leg without any fracture on X-ray on performing activity? That is what is known as popliteal entrapment syndrome. What is popliteal entrapment syndrome? Just listen to me. This is a congenital anomaly where the popliteal artery passes through the gastrocnemius muscle, and in these individuals the gastrocnemius is hypertrophied because they are athletes. And this gastrocnemius will cause compression of the popliteal artery, causing ischemia distal to it, which is gastrocnemius. Are you following? So it's a congenital anomaly, not a common thing. Normally, popliteal artery should not go through the gastrocnemius muscle. Congenital anomaly, gastrocnemius is going through the gastrosoleus muscle, and these individuals are athletes. Hence, their gastrosoleus is hypertrophied, causing compression or kinking of the popliteal artery. Hence, ischemia distal to it, that is the calf muscle. and complaining of pain on the posterior aspect of the leg on performing activity. So popliteal entrapment syndrome, pain at the back of the leg or calf after activity, X-ray normal. Medial tibial stress syndrome or shin splints, pain on the anterior medial aspect of the leg after activity, X-ray is normal. Okay? So this is the spectrum of the conditions that are seen in patients who are active, runners, marathon runners or truckers. Now, how do you treat any kind of stress fracture, whether it is march fracture or runner's fracture? Rest and immobilization. This is how you will treat any fracture. Now let's talk about fracture healing. Now when I say fracture healing, please understand that there are two types of fracture healings. One is direct or primary healing. The other is secondary or indirect healing. Now we will mostly talk about secondary or indirect healing because that is what is asked and is important. But you should know what it is. See, whenever there is a break in the bone, if the fracture is held very rigidly without any kind of movement, if it's a rigid fixation which has absolute stability, means no movement at all, you get something known as primary or direct healing. The bone basically, because it's so fixed, so rigid, the bone starts to grow into the other bone, and that's how it heals. That's how it heals. Now in secondary healing, which is indirect healing, what happens is between the fracture ends, there is some amount of micro movement. Please remember, I said micro movement. I did not say movement. I said micro movements, very, very fine movement. And because of this, healing happens, but it starts to happen from outside. This is known as callus formation. Okay, so callus will bridge between these two fracture ends first. This is known as bridging callus, and this callus will later heal between them. This is known as callus. This occurs because of relative stability. Mostly we'll talk about this because this is stronger and this is more common. This is what we are going to see. So now let's understand what are the stages of fracture healing. Okay, we're talking about secondary fracture healing. We'll talk about the stages of fracture healing. Again, as promised, everything's written in the slides. Just listen and understand. That's your job. Your job is to relax and listen. See, whenever there is a break in the bone, I've told you the bone has a nutrient artery in the center, has periosteum and endosteum. So whenever there is a break in the bone, the nutrient artery will break, the periosteum and endosteum will break, which will lead to bleeding at the fracture site, right? So there will be bleeding at the fracture site. This is known as fracture hematoma. Again, everything's written, don't write down, just listen. Bleeding at the fracture site, known as fracture hematoma. This is the first stage of fracture healing. Why is it first stage? Because this blood that is collected there, hematoma, it releases certain chemotactic factors that helps in aggregation and accumulation of fibroblasts. What is their job? The accumulation of these fibroblasts basically forms a fibrous meshwork between these two fracture ends, giving you the typical granulation tissue. Gives you the typical granulation tissue. This is the name of the second stage. The second stage is the stage of granulation or inflammation. What is happening here? The fibrous tissue forms a fibrous meshwork between the fracture fragments. These are fibroblasts. Okay, so far so good. Now the third stage of fracture healing is when these fibroblasts mature or differentiate into osteoblast. So they will start making the osteoid. So fibroblasts mature into osteoblast and they start making osteoid. And if you recall what is osteoid, it's the collagen meshwork. It's the cartilaginous, collagenous meshwork. That is what it is. This is known as the stage of callus. Again, please don't write. Listen, everything is written. Everything is written. Just listen to it. This is known as the stage of callus. So it's a stage of cartilage or a stage of callus. Okay, stage of cartilage, stage of callus. It has some mineral, but not enough to call it a bone. Then what happens? The stage of cartilage will start to get heavily mineralized and start to form a woven bone. Starts to form a woven bone. This is known as the stage of consolidation. You'll get woven bone. This is known as the stage of consolidation. Now this woven bone we all know is disorganized. It's still not organized. And so this woven bone needs to become lamellar and hence to undergo remodeling to become organized. The last stage is known as the stage of remodeling, where you get your lamellar bone, where the bone architecture, the endosteum, the periosteum, everything become normal. Okay, these are the stages of fracture healing. You are not writing a single word. You are just listening to me. Everything is written. You are not writing. Okay. Now if you want to write down, you can write down as promised. First stage, stage of hematoma. bleeding at the fracture site. It has chemotactic factors that aggregate fibroblasts. Granulation or a stage of inflammation. Growth factors released by the tissue matures the fibroblasts into osteoblasts. Callus stage. Osteoblasts produce osteoid, that is callus, that is relatively less mineral and it's mostly cartilage. Stage of consolidation, which is a rigid callus, basically osteoid, and calcium, which is irregular collagen woven bone. And finally, the stage of remodeling has a lamellar bone which replaces the woven bone. Okay? As promised, you can write down. You can pause the slide and you can write down. But coming back to a few more MCQs here. What are those? What is the first stage of fracture healing? MCQ number 1. First stage of fracture healing is hematoma formation. Okay. What is the last stage of fracture healing? Stage of remodeling. Right. Now I've talked about these stages, but did I tell you the duration of how long these stages last? Listen to me. It's complex to remember, but I'll try to simplify it for you. Just remember for the sake of your exam like this. Hematoma lasts for 2 to 3 days. Granulation lasts for 2 to 3 weeks. Lasts for. Callus lasts for 2 to 3 months. Consolidation lasts for 2 to 3 years. And remodeling takes more than 3 years. For the bone to be completely normal like the original bone before the fracture, it will require 3 years minimum. Okay, are you following me? So these are the durations I want you to remember for exam. In reality, there is some change, but for your exam, this is fine. So they will ask you this question. Callus is earliest visible by. Callus is earliest visible by 3 days, 3 weeks, 3 months, or 3 years. The correct answer is 3 weeks. Why? Because granulation lasts for 2 to 3 weeks. After 3 weeks, what will start? Stage of callus will start. Very good, interesting MCQ, right? Right. Similarly, consolidation earliest by 3 months. Now, what is the significance of callus and consolidation? Callus will be visible on X-ray. It's the first stage of healing visible radiologically. Callus. What is consolidation? It's the first stage of healing visible clinically. When you move the bones, they do not move. At stage of callus, yes, if you move the fracture ends, it will move because it's soft. But in the stage of consolidation, it will not move. Which means there are 2 more MCQs here now. Earliest stage of fracture healing visible radiologically is callus. Earliest stage of clinical union is consolidation. Right? Right. So remember this important point. Whenever a patient comes to you and he has a fracture, you have operated for that fracture. If you want to assess if the fracture is healing or not, radiologically, when will you get the next X-ray done? Not before 3 weeks. That is why most of the times patients come to us in the OPD following a K-wire fixation or a plate fixation. They say, sir, X-ray le lo. Just check whether it's healing or not. We'll tell them, beta, nothing before 3 weeks because after 3 weeks only callus will be visible. Okay? Which brings me to another important point. When does the bone completely heal? 3 years. At least 2 to 3 years it will take. That is why sometimes patients come to you and tell you if there is an implant in their bone. For example, if you put a plate or a nail or a rod, they will come to you after a few months, 6, 7 months, 8 months. They will say, nikal do, remove it, because they feel some foreign bodies inside their body. Then you tell them the bone has not completely become normal. So you'll ask them to wait at least 2 years. You will not remove the implant for at least 2 years. Okay? So these are some facts, but we have discussed the MCQs with it. Right? So remember, implant removal 2 years later by earliest, and callus visibility needs at least 3 weeks on X-ray. Now let me show you this callus. Here this is a fracture of the metacarpal, and you can see callus here. This is known as the bridging callus. It bridges the fracture. Again, can you see this callus here? This has healed very well. Again, this is the fracture end, and you can see callus here. It's less mineralized now, but because it becomes mature, if it becomes mature, it will be heavily calcified and more mineralized. Now, this is how a fracture will normally heal. Now, what are the abnormal outcomes of fracture healing? What happens when the fracture does not heal properly? The abnormal outcomes are 2 very important. One is non-union, where it is not uniting. Other is malunion, where it is uniting, but in anatomically abnormal fashion. So what causes this non-union? So what are the factors affecting the fracture healing? What is important for fracture healing? We all know the most important parameter for fracture healing is immobilization. Immobilization. You should not have movement at the fracture site, because if you have movement, the fracture will not heal. Remember, I told you movement. Micro movement is good. Not talking about micro here. Micro is good. We are not talking about that. That is only because of the implants. We're talking about general movement. If there is movement at the fracture site, means if you have not splinted it properly, if you have not used the bandage properly, if you have not used the POP cast properly, then there is movement at the fracture. So improper immobilization is the most common cause of non-union. Please remember this. What are the other causes? There can be patient causes, there can be fracture causes, there can be tissue causes or treatment causes. Patient causes means age, extremes of age, elderly patient, poor health, alcoholic, tobacco, smoker. Smoking is a very common cause of non-union. Please remember that. But the most common is improper immobilization. Types of fracture: open fracture, contaminated fracture, fracture with interposed soft tissue or muscle. They will not heal. Tissue factor: if there is ischemia of the bone, how will it heal? Treatment factor: you not reduce the fracture properly, bones are like this only. Or if there is improper immobilization, the most common cause is improper immobilization. Okay? So what is non-union? Non-union is basically arrest in the healing process. So what is the definition? Arrest in healing process. We do not have a chronological definition. But for simple understanding, a lot of people assume that it is 9 months. So if there is no callus by 9 months, we call it non-union. Means there is no attempt of bone to heal by 9 months, we call it non-union. If there is no attempt by 6 months, we call it delayed union. But please remember, in delayed union, if you take serial x-rays, for example, if you take an x-ray today and repeat x-ray another after 1 month or 2 months, you will see some callus proliferation. Okay? But it is not healed. But callus is progressing but slow. That is called delayed union. And delay, union ho raha hai, it's uniting but slow. Non-union, it's not uniting only. So if there is no union by 9 months, we assume it as a non-union. Now, which bones will most likely go into non-union? I've told you, recall this. Diaphyseal bones, because they are more compact and less vascular. Whereas cancellous bones will be more vascular. So hence, no non-unions. So metaphyseal fractures usually undergo malunion. Diaphyseal fractures usually undergo non-union. And the most common bone to undergo non-union is tibia. Particularly the lower 1/3 tibial fractures, it usually undergoes malunion because of 2 reasons. One is diaphyseal, another it has very less or compromised vascularity. Anyways, moving on to the types of non-union. There are 2 important types of non-union for all intents and purposes. Okay, but classification mein to bahut sare hain, but 2 very important. One is hypertrophic non-union, other is atrophic non-union. Hypertrophic and atrophic non-union. Oligotrophic is there also, but we'll just remember hypertrophic and atrophic. So what is non-union? Non-union is basically a fracture whose fracture line is still visible. Okay, fracture line is still visible. Listen, here this is hypertrophic non-union and this is atrophic non-union. First, I will show you what is the similarities between the two, and then I will show you what is the differences between the two. The similarity is that both of these non-unions, the fracture line will be visible. Are you able to see the fracture line? Yes, fracture line is visible. Second, the ends are smooth. Ends are smooth and sclerotic. Sclerotic means more dense, more white. Why smooth? Fresh fracture, usually the ends are serrated. Something that is chronic has become smooth. That is the significance. So fracture line is visible, ends are smooth and sclerotic. Ends are smooth and sclerotic. Okay. Third thing, there is no bridging callus. Listen to me carefully. I said bridging callus. Here you are noticing that there is exuberant callus, but there is no bridging callus. It is not bridging to the other part of the bone. Okay, here too there is no callus at all. Okay, here there is no callus at all. So similarities are this. What are the differences? The differences is that in hypertrophic non-union there is some callus, at least no bridging callus, but callus is there. But in atrophic non-union there is no callus at all. Okay, so hypertrophic non-union, fracture line visible, ends smooth and sclerotic, exuberant callus but no bridging callus. Whereas atrophic non-union, fracture line visible, ends smooth and sclerotic but no callus. So for all intents and purposes, hypertrophic non-union there is callus but there is non-union. In atrophic non-union there is no callus. Okay, like I promised, everything that I have said is written here. Okay, now listen to me. What is the difference then? Key difference here. There is callus in hypertrophic non-union and there is no callus in atrophic non-union. But why? In hypertrophic non-union, you see the biology of the fracture ends are good, is healthy. The bone is healthy. It wants to unite. That is why there is so much callus. It's just that it is not properly immobilized for the callus to bridge. The problem is immobilization. So hypertrophic non-union, bone biology is good, proper is immobilization. So all you have to do is just immobilize the fracture and the fracture would heal, right? That's it. So it's a problem of immobilization. What about atrophic non-union? Atrophic non-union, there is no callus, means the bone is not healthy, means the bone is not even attempting to unite. So there is some pathology in the underlying bone. It could be ischemia, it could be something, whatever it is. The bone is not healthy, and even if you immobilize it perfectly, it will not unite. So now you have to do something to stimulate its union. You have to induce union by stimulating the union. That is where your bone graft comes in. You not only have to immobilize the fracture, but you also have to put bone graft to stimulate the fracture to heal. That is what is the treatment of atrophic non-union. So for all intents and purposes, when we say non-union, we are typically talking about atrophic non-union, which requires bone graft to heal, not hypertrophic non-union, unless specifically mentioning hypertrophic non-union. Okay, na? Are you understanding? Typical non-union is atrophic non-union, whose treatment is bone grafting and immobilization. Right? Now look at this. Hypertrophic non-union versus atrophic non-union. Biology is good. Biology is abnormal. Improper immobilization. Immobilization may be good. Treatment is to immobilize. Treatment is to immobilize as well as give bone grafting. That is the thing. So for all intents purpose, this is the typical non-union that we are talking about. Why bone grafting? How will bone grafting help stimulate the fracture healing? Beautiful question. Let's discuss that. Now, where do you harvest this bone graft from? The most common source of harvesting the bone graft is the iliac crest. Okay, iliac crest, you make a hole in the iliac crest and you remove the bone from it and put it at the fracture site. Now this bone graft, autologous, it comes from the same individual, autologous bone graft, has certain characteristics. So we need to know what are the good characteristics of the bone. The ideal bone graft should have these three characteristics. One is osteogenesis, osteoconduction, and osteoinduction. Again, first listen to me, understand, and then you can write the notes. Osteogenesis property is basically a property of the bone graft to grow new bone on its own. Osteogenesis. It makes new bone on its own. So nobody can do it. It has to be an osteoblast or an osteoprogenitor osteoblast to do it. Right? So it has to be that to make new bone. What is the osteoconduction property of the bone graft? Osteoconduction property of the bone graft is to basically act as a canvas over which bone grows. So this bone graft will act as a canvas over which the bone will grow. So one property of a good bone graft is that it should have osteogenic potential. It should produce new bone on its own. Second property is that it should have a canvas. It should be scaffold-like. It should be a large surface area like bone on which the bone will grow, on which the vascular elements will grow. And the third is that it should induce the surrounding neighboring tissue to grow new bone. So it should be osteoinductive. An iliac crest autologous bone graft has all three characteristics. But please remember, an autologous bone graft is not infinite. It's only finite. A limited amount can be harvested. But if you want artificial bone supplements, are they available in the market? Yes. But they will not have all the characteristics. They will have some of the characteristics. So what are these characteristics? We have talked. Now let's read. Osteogenesis is when the graft itself forms bone with the help of osteoblast. So this can only be natural. Artificial will not be available in the market. Osteoconduction is when the graft allows for the growth of the bone on it as a scaffold on its surface. So this can be a natural bone or it can be an artificial calcium phosphate crystals, calcium sulfate crystal, polymethyl methacrylate crystals. Look at this. These are the crystals. You break them and you put it in place of the bone graft requirement and the bone will grow over it. Osteoinduction is something that can stimulate the host to form bone. These can be created artificially by recombinant technology. We have bone morphogenetic proteins that we have synthesized which stimulate the surrounding tissue to form bone. Okay, so we use this bone morphogenetic protein to coat on the implants that we use in orthopedics. We coat it on the implants, and when we put the implants, they release these osteoinductive substances that stimulates bone to heal. That stimulates the fracture to heal, right? It's nice. So this can be made artificially. This can be made artificially. Osteogenesis is not something that can be done artificially. So substitutes of bone graft with the following properties. The bone conduction property I've told you, calcium phosphate, calcium sulfate and polymethyl methacrylate, and bone induction properties, bone morphogenic proteins, These stimulate the host cells to manufacture bone. Nowadays, we are getting artificial bone substitutes that have both the properties. They act as scaffold or canvas, and they are also osteoinductive. Okay. Now, the other abnormal outcome of a fracture healing process is malunion. What is malunion? Healing is healthy. Bone is healthy. The bone has healed, but it has healed in anatomically abnormal fashion. That is the problem. It's just that somebody did not reduce the fracture properly, or they did a horrible job about it. Right? That is malunion. It's like it has united. It's teda hai par mera hai. It has united but abnormal fashion. That is what is malunion. Look at this. The bone has healed but in anatomically abnormal fashion. Now, normally, if there is no functional problem, we usually do not interfere. If it's a cosmetic problem, we usually do not interfere unless and until the patient would want it. But if there is a functional problem, then we would go and cut the bone, realign it and fix it. So cutting the bone is osteotomy. Okay, that's all there is to malunions. So certain fractures usually undergo malunion, certain fractures usually undergo non-union. So we need to know the list for the sake of the exam. And another reason I want you to remember the list of your exam is that the bones that usually undergo malunion rarely undergo non-union, and the fractures or bones that usually undergo non-union rarely undergo malunion. And this knowledge will become immensely powerful for you to rule out options on the exam. So fractures that usually undergo malunion are clavicle, supracondylar humerus, Colles and intertrochanteric fracture of the femur. Fractures that usually undergo non-union are lower 1/3 tibia, lateral condyle humerus, scaphoid and neck of femur and neck of talus fracture. The fracture that most commonly undergoes malunion is clavicle, and the fracture that most commonly undergoes non-union is lower 1/3 of tibia. Now let's talk about management of a fracture. Now you see, whenever we talk about the management of the fracture, it involves the investigation and the treatment. Now there will be terminologies that will be thrown around. If you start your internship or if you go to the wards, there will be these terms that will be thrown around and you will be unable to understand what's going on. So it's my job to help you understand what those terms are. The terms are displacement, reduction, attraction and fixation. What are these terms? Very simple. Let's start with the displacement. What is displacement? Again, as promised, everything is written. Listen to me. Whenever there is a fracture, the bone after the break will move. Either it will move anteriorly, posteriorly, medial or lateral. Which part will move? The distal part of the fracture. Because proximal part is still assumed to be attached to the body. For example, say this is the human being. This is skeletal system. If there is a fracture here, this part will start moving. So we'll describe the displacement in the distal fragment, not the proximal fragment, because proximal is still attached to the body. Are you following me? So the displacement of the fracture can be anterior, posterior, medial or lateral. Now look at this X-ray. This is a lateral view of which bone? Of elbow. What is this bone? This is humerus, this radius, this ulna, right? There is a fracture here of the distal end of the humerus. This is particularly a supracondylar humerus fracture, where the distal fragment is gone in extension or posteriorly, right? Extension or in posteriorly. So displacement is considered posteriorly. We are not talking in terms of the proximal fragment because it is considered normal, still attached to the body. So that is the terminology we'll use. So that is when they say the fracture is laterally displaced, medially displaced, anteriorly displaced, posteriorly displaced. Dislocation is anterior, dislocation is posterior, dislocation is inferior, right? So that is the terminology. Now what is reduction? Reduction basically means bringing the displaced fracture back to normal anatomy. Why? Because you do not want the fracture to unite in that abnormal fashion. Because we just read, we want the fracture to unite normally. To prevent malunion, we need to bring it back to normal. Which brings me to the question, why was the fracture displaced in the first place? The fracture was displaced in the first place because of two reasons. The first reason is the fracture force, or the trauma, the velocity of the injury. Second is the strong muscular pull. Now, what is the muscle that is pulling this olecranon? Triceps. And that is what is causing the displacement. Now, when you're attempting to reduce the fracture pattern back to normal anatomy, you obviously have to counteract the force of this displacing muscle, right? So the force that you apply to reduce the fracture, which counteracts the pull of the muscle causing the displacement, is what is known as traction. So when you're trying to reduce the fracture back to normal anatomy, you have to apply force, and this force is known as traction, which is equal and opposite to the force causing the displacement, which is the force of the muscle. Everything is written. Are you understanding? Are you following? The traction force should be more than the force of the muscle causing the displacement. That is the traction force. And whenever you give traction, remember friends, you have to give counter traction. Otherwise, when you're giving traction, the patient will come towards you. You don't want the patient, you just want the fracture to be reduced. Okay, so whenever you give traction, you give counter traction. So traction, counter traction. I'll show you the images, everything will make sense. And finally, once you've reduced the fracture, you would want them to be in the position of reduction till the fracture heals. Right? For how long will it take for the fracture to heal? 3 months to bola tha na, I told you 3 months. So how will you hold on for 3 months? You can't, right? So you need something else to hold on for you. That is known as fixation. So any device that keeps the fracture in reduction is a fixation device. Any device. It can be the POP splint that you apply. It can be a plate, a screw, a rod, a nail or a wire or anything that you put in to keep the bone in its place. Inside the body or outside the body. That is fixation device. General idea, right? Are you following the terms here? Right? Right? Okay? So look at this displacement. It's the relationship of the movement of the bone distal to the fracture site. They displace due to the pull of the muscular force and the velocity of injury. What is the reduction? Bringing the fracture fragments back to the normal anatomy by application of force to counter the pull of the muscle. Discussed. What is traction? The application of force to counter the muscular force causing the displacement applied with counter traction. It cannot be without counter traction, otherwise the patient will come with you. Fixation to keep the fracture in reduced position till it heals. Right? Okay? So far so good. Displacement, so you have understood. Reduction, you have understood. What about tractions? How can you apply tractions? There are many methods of application of traction. One is with your hands, known as manual traction. Manual traction. You apply it with your hand. So this is traction, this is counter traction. Skin traction. What is skin traction? You wrap a bandage around the limb and then you pull the bandage. You're pulling the bandage. You wrap a bandage and you pull the bandage. Skeletal traction. Skeletal traction. You put a pin in the bone and then you attach a device to that pin and then you pull the pin. So when you're pulling the pin, you're pulling the device, you're pulling the bone. Right? This is a skeletal traction. Manual traction, skin traction, skeletal traction. Everything has their role, everything has their advantage. Manual is obviously non-invasive. Skin is also non-invasive, a little more forceful. Skeletal is invasive, obviously more forceful. So you can use mild force here for skin, moderate to severe force for skeletal traction. This is the force of traction, 5 kg or 15 kg. And this skin traction, Bucks traction or Bucks bandage, or here you'll put pins on a Steinman pin or Denham pins or K wire or Crutchfield strong. So many things are available. Okay, so look at this image. Here we are applying traction and this gentleman over here is counter traction. Let me show you a video of this procedure now. Now in this video I would like to show you the procedure of close reduction and POP application. For reference, this is a patient who has an extra-articular fracture of the upper limb and we want to basically manage it by close reduction and POP application. Now this is the forearm, as you can see in front of you, this is the forearm, and there are 3 people standing in front of you and I'll tell you what their jobs are. This gentleman over here is basically applying the traction. He's pulling the distal part of the limb to distract the fracture so that the fracture can be reduced. And this gentleman over here, who's holding at the elbow, is the gentleman who's providing the counter traction. So there is traction being applied and counter traction being applied. So the forces that are acting on the fracture fragment to cause the displacement is we're trying to neutralize those forces. And this gentleman right in the middle, he is waiting for the traction forces to act and then he will manually reduce the fracture with his palms and he will try to hold that reduction, and then we will slowly apply the cast padding, that is the cotton roll, and then we'll apply the plaster of Paris and I'll show you how it is going. Traction is being applied, there is counter traction, and this gentleman in the middle is palpating for the fracture and now he's trying to manually reduce the fracture. Now once he's happy with the reduction that he's achieved, we will apply the cast padding or the soft roll or the cotton roll. As you see, this is the soft roll or the cast padding or the cotton roll that is applied. Basically, it helps absorb the sweat and the exudate and keeps the limb dry while we apply the plaster of Paris above it. This is the plaster of Paris. Calcium sulfate hemihydrate mixed with water becomes calcium sulfate dihydrate. Now we have placed it only on one particular part of the circumference. We have not covered it completely. So this is a slab or a splint. This is not a cast. Cast is circumferential. The reason we have not used a cast in this case is because this is an acute injury and there is chances that it will swell up because of the injury, and we do not want compartment syndrome. So we are only using a splint or slab that is covering it on a part of the circumference that will allow for the swelling to happen, minimizing the risk of compartment syndrome. Obviously, the reduction will not be maintained very nicely with this, but that is not the idea here. The idea here is to just support the fracture for now. And later when the swelling comes down, we will convert this slab or splint to a cast completely by encircling the plaster of Paris all around the circumference of the limb. Now once this slab is applied to a particular part of the circumference, we will keep it in place with the help of the gauze roll or the roller bandage. He's applying the roller bandage all around to keep the slab in place. And now he's molding the POP to the desired shape to keep the fracture in reduction. He will hold it for some time till the POP starts to heat up and set, and then the slab will be good to go. This is the procedure of close reduction and POP application. Obviously, you must understand now that the fracture reduction will not give you an ideal or perfect reduction because you have not observed the fracture under vision, but you will definitely use X-rays to confirm your reduction has been done or not. It will not be perfect, but you'll get the job done. Since it's an extra-articular fracture, we do not require perfect articular alignment. We can get away with, acceptable reduction. So this is close reduction and POP application. So here you can see this gentleman over here is providing the traction and this gentleman here is providing the counter traction, and hence the fracture will be reduced. Okay. Again, you can see here, this is skin traction, skin bucks traction is applied, and this gentleman is pulling, and there is a splint that is provided here. That is Thomas splint that is providing the counter traction. I'll just explain this in a bit, and this is how you're applying skin traction on a Thomas splint. And these are the devices or the instruments you will use to apply the skeletal traction. I'll just show you in a bit how to apply the skeletal traction. This is the drill that we are using. This is the local anesthesia. This is a straight artery. And this is the 11 number surgical blade. And these are the pins. One is a Denham pin, other is a Steinmann pin. And this is a Böhler stirrup. This is a Böhler stirrup. And these are the pins that I was talking about that you put in the bone. This is the Denham pin, which has threads in the center. This is usually used in cancellous bone. And this is the Steinmann pin, which is smooth. This is used in normal, healthy, young adult bones. Now let me show you a video of how we perform the upper tibial skeletal traction or upper tibial pin traction. Now in this video, I would like to demonstrate the upper tibial pin traction or skeletal traction that we apply to keep the fractures reduced. Now the instruments that we will use, I will show you step by step. This is the instrument. This is your Böhler's stirrup, or you call it the skeletal traction bow as well. Now these are the things that we need. This is the drill. And we have a local anesthetic, 2% lignocaine is fine. And we have 11 number scalpel blade, and we have the artery forceps. Now there are two pins that I would like to bring attention to you. Is number one, we have Steinmann pin, and we also have Denham pin. I'll show you the details now. Now Steinmann pin is a smooth pin, whereas a Denham pin is also a smooth pin, although in the center right around here you are seeing these threads. The Denham pin is basically used in osteoporotic bones, whereas Steinmann pin is used in stronger bones. Otherwise, Denham pin is usually also used for calcaneal tractions, and Steinmann pin is preferred for tibial or femoral tractions. Now I want to orient you to the video that I'm demonstrating here. This is the knee joint, nicely draped and prepared. This is the proximal part of the leg here. You can see the knee joint, and you can see this prominence over here. This is the tibial tubercle. What we are doing is, after preparing the site, we are localizing the location of insertion of the skeletal traction pin or the pin traction, which is ideally 2.5 centimeter below and behind the tibial tubercle. You can clearly see that this is the tibial tubercle, and the needle is being marked just 2.5 centimeter below and behind the tibial tubercle. I'm trying to inject the local anesthetic here all the way in the skin, the subcutaneous tissue till the bone, and this is the lateral side of the leg, and this is the medial side of the leg. We always enter through the lateral side of the tibia and then go out or exit from the medial side. You can see the tibial tubercle being demonstrated, marked 2.5 centimeter below and behind, and local anesthetic is being injected from the skin, subcutaneous tissue all the way up to the bone. This is the entry site. We do not want the patient to be in pain, and we are also doing the same for the exit site, where we are inserting the local and where we are injecting the local anesthetic on the exiting site. Now, once we have marked the site for insertion, we are using an 11 number scalpel to make a puncture or a stab wound from the skin, soft tissue up to the bone, so that the skin is not burnt or there is friction while we are passing the Steelman pin. Or sometimes if the Steelman pin or the trocar of the tip is sharp enough, we directly go ahead and drill the tibia with the drill itself. So the stab incision is being made here. Now you can see that we are using an artery forceps here to dilate the entry site or the entry wound, so that we can access the bone and make sure there is no soft tissue in the path of the pin. So we are dilating and clearing and making sure that there is no soft tissue on the way. Now this is the Denham pin that we are showing you here, clear pin, and you have the central part which is threaded. This obviously, because the bone is osteoporotic, must be an elderly female on which we are using this. Now it is mounted over the drill and the pin is placed on the bone. Again, reconfirmed that it is just 2.5 centimeter below and behind the tibial tuberosity. Now attached to the drill, and in full speed we are drilling all the way from the lateral to the medial side, perforating the bone, the soft tissue, the fascia, and the pin comes out on the medial side through the skin. You can clearly see that it is coming out here. And we'll make another stab incision just to help the pin come out easily without damaging a lot of soft tissue and skin. And it has successfully come out. So it has come out on the medial side now. Now we'll remove the drill and apply dressing here so that the entry site and the exit site does not get infected, because the most common infection for pin tract sites is infection by organisms Staphylococcus aureus, and we do not want that. And also remember, following the application of these pin tracts, you can get a pin tract sequestrum, which is a ring-shaped sequestrum around the entry and the exit site of these pins. In order to prevent that, we are covering it nicely with this betadine soaked gauzes. Now we are using the Bowler stirrup that I have shown you in the images and mounting it over this Denham pin nicely, making sure it is equal on both the sides. Now we'll lock the stirrup to the pin, and you can clearly see that this Bowler stirrup would be free over the Denham pin. Clearly see that it is free and still mounted on the pin. Now this ring that you see over the stirrup at the end of the stirrup is the ring where we tie our skeletal traction rope. Towards the end of that rope we have our weights. It can be somewhere around 10 kgs, 15 kgs or 20 kgs that will help us keep the fracture reduced for lower limb fractures. So this is your upper tibial pin traction. These are the steps that we perform and make sure that the wound is neat and clean, because at the end of the day it's an invasive procedure where you're putting a foreign object through the bone of the patient. It can be used for majority of the fractures in the lower limb, particularly your intertrochanteric fracture, your femur fracture, your distal femur fracture, and it helps the fracture to be kept in reduction. And you can now mount this patient either on the Bowler and Brown splint or the Thomas splint or any other kind of splint of your choice. And now that you've applied the skeletal traction, the force of the string or the rope that you will pull, it will depend on the pulley which you use on the splint. So this is a Bowler and Brown splint over here. Now this splint has 3 pulleys, pulley A, pulley B, pulley C. The pulley A, the direction of the force will be in this line, so usually use it for tibia fractures. Pulley B, the direction is in this, the force is in this direction, so you usually use it for femur fractures. And pulley C, the purpose of the pulley C was basically to keep the foot straight, preventing foot drop, preventing plantar flexion. So use pulley C to prevent foot drop. So these are the 3 pulleys of Bowler and Brown splint. Now while we are on the topic of splints, I wanted to understand 2 very important splints that we use in orthopedics. One is Thomas splint, the other is Bowler and Brown splint. Both of these are used for splinting the fracture. See, what is the purpose of splinting the fracture? Purpose of splinting the fracture is basically to support the fracture to minimize pain. Now there are many splints available in the market that are either only supportive or provide traction and counter traction in itself to keep the fracture reduced while splinting it. One of such is Thomas splint. So let's talk about Thomas splint. This was invented by H.O. Thomas. H.O. Thomas. This is this gentleman. Okay. He's considered as the father of British orthopedics. He's considered as father of British orthopedics. There is another MCQ, very old, outdated question. Father of orthopedics. Father of orthopedics is Nicolas Andre. Nicolas Andre. Okay, very old, outdated MCQ. He's father of orthopedics, but father of British orthopedics is H.O. Thomas. Father of modern orthopedics is Sir Robert Jones. Right? These are three fathers you should know. If you know, okay. If you don't know, that's also okay. Okay. So father of orthopedics, Nicolas Andre. British orthopedics, H.O. Thomas. Modern orthopedics, Sir Robert Jones. Anyways, so this father of British orthopedics invented Thomas splint. And the interesting thing is that he originally invented this splint for his wife who had tuberculosis of the knee. And this was also an MCQ for some reason. Anyways, we don't use it for TB knee anymore. We use it for lower limb fractures, particularly femur fracture. The beautiful thing about this Thomas splint is that it has a ring and two rods. This ring goes and sits on your perineum and the ischium. It goes and sits there. The beauty is that the lower limb is passed through it. Okay? The lower limb is passed through it like this. And after application of skin traction or skeletal traction, the ropes of the traction are pulled and applied tightly to the traction itself. Now what happens? The traction is there by the ropes, skin or skeletal, and the ring is pushed as counter traction. So there is traction and counter traction in a single device. So this is a beautiful device which provides both traction and counter traction to keep the fracture in reduction. This is known as a fixed traction device. This is a fixed traction device. So Thomas splint is a fixed traction device where traction and counter traction are working together to keep the fracture reduction. This was a beautiful device that was useful in the war time, where if a patient has a femur fracture, they would quickly apply this Thomas splint. And because it's a device that both has traction and counter traction in it, it was a fixed traction device, the patient was mobile. The patient was rendered mobile. Traction laga diya, chhod diya patient ko. You can move the patient however, wherever you want to because the fracture is reduced and maintained. Beautiful device, useful in a wartime. Okay, now if you're preparing for a professional exam, sometimes they ask you this in a short note. So these are the things that you can write about Thomas splint, but not very important for your MCQ exam. Moving on, Bowler and Brown splint. Another splint that I want you to know is Bowler and Brown splint. Now this Bowler and Brown splint was invented by two gentlemen, Dr. Bowler and Dr. Brown. This splint is also used for lower limb fractures, particularly femur fracture and tibia fracture. I've told you depends on the pulley that you use of the splint. It can be used for tibia fracture if you use pulley A and femur fracture if you use pulley B. Okay. Now what is this device? This is a sliding traction device. Sliding traction device where once you apply the skin traction or skeletal traction, you hang the weight. This is providing the traction. But what is providing the counter traction? In Thomas splint, the ring was providing the counter traction. Here, what is providing the counter traction? Here you have to raise the bed. Here you have to raise the bed. Look at this. We have kept bricks under the bed here. Why have we done that? To raise the foot end of the bed. When you raise the foot end of the bed, the body of the patient will slide with gravity. The body of the patient will slide with gravity and the weight will provide the traction. The sliding body weight will provide counter traction and the fracture will be reduced nicely. This is why it's known as a sliding traction. But obviously because the the foot end of the bed has to be raised, can you move the patient easily? No. The patient has to be moved with the bed. So this is not a very mobile device. So this is used in a ward setting. It's usually in ward setting, whereas Thomas splint was used in war setting. Thomas splint is a fixed reduction device. Bowler and Brown splint is a sliding reduction or a balanced traction device. So Thomas splint is a fixed traction device and Bowler and Brown splint is a sliding or a balanced traction device. Another example of sliding or balanced traction device is Russell's traction, which is used for intertrochanteric fractures of the femur, and this was asked as an MCQ. Now let's talk about the definitive management of the fracture. Here I will give you a very important algorithm. You see, in orthopedics, when we fix a fracture, we fix it however we like based on our guidelines, and the guidelines are so all over the place. For example, you will put a plate for an upper limb bone, for a lower limb bone. You will put a screw for a fracture. You can put a nail for a fracture. You can do K-wiring. You can do stainless steel. You can do tension band wiring. You can do so many things for a fracture. But if that is the case, how will you remember the treatment of any fracture then? In reality, you can actually do anything for any fracture if you know how to do it. But that should not be the case for an entrance exam. So for your sake, what I have done is I have given you an algorithm that gives you a general idea of how do you manage a fracture. Okay, so this is the definitive management of a fracture. But before we go and talk about it, please understand the two things. First, the fracture needs to be reduced. Second, it needs to be fixed. So there are two techniques of reduction, two techniques of fixation, generally speaking. So let's see. There is an open reduction and there is a closed reduction. Now, what do you mean by open reduction? What do you mean by closed reduction? Closed reduction is when you attempt to reduce the fracture without actually opening the fracture sites. How do you go about doing it? By feeling, by palpating, by looking at it under an X-ray or an image intensifier, that is a portable X-ray in the OT, the theater, right? So I'll show you all of this, but just please understand. So closed reduction, where you feel for it. Look at this gentleman. One is providing traction, other is providing counter traction, and this gentleman is trying to reduce the fracture by force over the skin without exposing the fracture hematoma. Then there is something known as open reduction, where the surgeon is actually opening or cutting open the fracture site to visualize the fracture hematoma and reduce the fracture under vision. That is open reduction. So you see closed reduction, open reduction. Closed reduction when the fracture is being reduced without visualizing the fracture site, without opening the fracture site surgically. You can visualize it under the X-ray or CM or image intensifier. Open reduction is when you open the fracture hematoma, visualize the fracture under vision and reduce it under your vision. So tell me, before we proceed, which of the two reduction techniques will give you accurate reduction? Obviously, it is open reduction, because in open reduction, you are reducing the fracture fragments under vision, so the reduction will be accurate. Whereas in closed reduction, it will not be very accurate but acceptable. In this video, I would like to show you how open reduction and internal fixation is done. Can you recall what open reduction internal fixation was? It was basically reducing the fracture site under direct vision. And how will you reduce the fracture site under direct vision? Only if you open the fracture site, meaning you incise the skin and the fascia and the soft tissue, reach the bone, visualize the fracture under vision, reduce it, and mount a plate and screws to reduce and fix it inside the body. That was open reduction and internal fixation. For reference, this is a patient with their forearm supine on the forearm table here, and this is this side, this is the radial side, and this is the ulnar side. We are going to take an incision now over the radius on the volar side. We are starting with a skin incision over the radius on the volar aspect of the forearm. Here the skin and the subcutaneous tissue is being cut. You can clearly see that we have made an incision now on the skin, and we are removing and cutting the subcutaneous tissue. Now we are going for the deeper dissection now. The deep fascia is cut and the muscle is being explored to reach the fracture site. Now we have reached the fracture site. Obviously there will be a lot of fracture hematoma over here, which we will wash with sterile normal saline, and thus removing the fracture hematoma. And then we will visualize the fracture site under direct vision. We will strip the soft tissue that is there between the fracture fragments. Sometimes there is a soft callus that has already started to form if the fracture is a little older. Sometimes there is periosteum between the fracture sites. Sometimes there is an interposing muscle or other soft tissue that needs to be removed or moved away from the fracture site. We use a periosteum or a bristow to move away those structures between the fracture fragments. Now you can clearly see that we are stripping the soft tissue away from the bone. And now you can see that we have used bone holders to hold the fracture fragments, the proximal and distal, and now we have nicely reduced the fracture. Can you see this fracture line perfectly reduced in alignment under direct vision? This obviously would not have been achieved with close reduction. Now once reduced, we will keep the plate over the fracture site. We have kept a dynamic compression plate over the fracture site, and we are using the bone plate holding forceps to keep the plate on the fracture site so that we can comfortably drill holes and put the screws without the plate moving away from the fracture. We're taking a drill and making the drill holes. The drill holes are being made. Now we are placing the screws in the drill holes. Now we are tightening the screws here. These are cortical screws because we are fixing the diaphysis. And once that is done, the fracture is nicely reduced and internally fixed. We are putting a drain here so that the collection should be minimal at the fracture site. And now we are closing the subcutaneous tissue and the skin. This is how an open reduction internal fixation is done, because it gives you an ideal reduction because it's done under vision and there is no confusion. And if you recall, I've told you in the basics, it is used for all intra-articular fractures and upper limb extra-articular fractures. Open reduction, internal fixations are usually done with a plate and screws. It can also be done with other devices like, and tension band wiring, you all know, is used for fracture of the patella and olecranon as far as your exam is concerned. Okay, now tell me, which fracture requires perfect reduction? Which fracture requires acceptable reduction? For that, I want you to understand there is something known as intra and extra-articular fractures. Now, what is intra-articular fracture? What is extra-articular fracture? Intra-articular fracture is a fracture passing through the articular surface. So, look at this. This is the bone. Fracture line passing through like this is extra-articular fracture. It's not involving the articular surface. Fracture line passing like this or like this involves the articular surface. This is an intra-articular fracture. So, this intra-articular fracture will disrupt the shoulder articular surface, right? So intra-articular fractures are fractures that pass through the articular surface of the joint line. Extra-articular fractures are outside the joint surface. So obviously, which of these two fractures require accurate reduction? Tell me. Intra-articular fractures, right? So intra-articular fractures require accurate reduction. So for all intra-articular fractures, what type of reduction will you prefer? Open reduction, right? I'll give you the algorithm, but please try to understand. So all intra-articular fractures, what will be the technique of reduction? Open. And now since you have already surgically opened it to reduce it, why not fix it inside? So what type of fixation will you go for? Internal fixation. So for all intra-articular fractures, you will do open reduction and internal fixation. In extra-articular fractures, what can you go for? You can go for close reduction and then you can stabilize that fracture with a POP. You can go for close reduction plus POP. Right? Now let me show you. Alright, now let me show you and put it on an algorithm for you. So there is a fracture. What is the first thing you should see? Whether it's an intra-articular fracture or an extra-articular fracture. Okay? If it's an intra-articular fracture, what will you go for? You want perfect reduction? You'll go for open reduction. And since you've already opened for reduction, why not fix it? Go for internal fixation. And what is the usual device that you will use? You will use plates. You will use plates. So for all intra-articular fractures, we'll go for open reduction, internal fixation with plates. Okay? Right. For extra-articular fractures, the first step would be go for close reduction and POP application. You go for close reduction and POP application. So look at this. This is an extra-articular shaft of humerus fracture. You are going for close reduction POP application. Right? This is suppose there is an extra-articular forearm fracture. Although that is not the cast that you will use, we will learn about that later. But for example, there is a forearm fracture, which is an extra-articular fracture. You can use a close reduction POP application for that. Okay? But please understand this one very important point. Whenever you are applying a POP, there are certain advantages and disadvantages. The advantages, non-invasive, easy to apply, non-invasive, easy to apply, easy to remove. All of that is great. But the cheap, non-invasive, easy to apply, easy to remove, cheap. But the disadvantage is that since you are applying it from outside, it will not keep the reduction nicely. Number one. Number two, it is very cumbersome. Number three, you have to immobilize the joint above and joint below, and the limb will go into atrophy and there will be stiffness and there will be so many other complications. That is why nowadays we are moving away from that and going towards better treatment options. So what are the better treatment options for extra-articular fractures? Now then, you will have to look for where the fracture is. If the fracture is in the upper limb or if the fracture is in the lower limb. If the fracture is an upper limb extra-articular fracture, that is shaft of humerus, shaft of radius, shaft of ulna, so it's an upper limb extra-articular fracture, you will go for open reduction, internal fixation with plates yet again. That is the definitive treatment for upper limb extra-articular fractures. Right? If it's a lower limb fracture, that is an extra-articular fracture, then the definitive treatment or the best treatment modality would be close reduction but internal fixation with rods or nails. And I'll explain how. Just remember this algorithm. So any fracture, intra-articular, extra-articular. Intra-articular, open reduction, internal fixation with plates, done, dusted, finished. Extra-articular, you can go with close reduction POP, but we know the problems of POP. Sometimes reduction does not hold. It is very cumbersome. So the definitive treatment, the better treatment will be surgical. What surgical option will you give? Upper limb versus lower limb. Upper limb extra-articular, go with open reduction, internal fixation with plates. Lower limb extra-articular, go with close reduction, but internal fixation with rods or nails. Now you will ask me, sir, you've told me you have opened the fracture. You're visualizing the fracture, you're reducing it, and then you can keep a plate on it because you're seeing the fracture under your vision. So it's an open reduction, internal fixation. How are you doing internal fixation? By closed reduction in the lower limb extraarticular fractures. How are you doing that? For that, look at this. Suppose this is your femur, right? And there is a fracture here. There is a fracture here. So what you do is you make a hole here, or you make a hole here. You make a hole proximally or distally. Mean you open the skin here, you open the skin here, but you do not open the skin at the fracture site, right? So when you do not open the skin at the fracture site, it means that you do not do open reduction. You will use a C-arm or an image intensifier or an X-ray to reduce under the X-ray, and then you will pass a rod here, and that rod will pass through the medullary cavity of the femur or the tibia. That is why it is called intramedullary interlocking nail or intramedullary nail. Intramedullary nail, that is the device you use. So look at this now. This is a fracture of the shaft of the femur. So it's an extra-articular lower limb fracture. So what do? I take this patient in the operation theatre and under the image intensifier, the CM, I'll show you the photos in a bit, and reduce this fracture. And I'll make a hole here. I'll make an skin incision here, and I'll make a hole in the bone here and pass the intramedullary nail from this side all the way through the fracture distally. That is the aim. So we are not opening the fracture site. Hence it is close reduction, but we are fixing the bone inside, internal fixation with intramedullary nail, and it is usually interlocked with screws, so we call it intramedullary interlocking nail or rod. Let me show you. So this is the X-ray, and this is the portable X-ray or the image intensifier or the C-arm that we called, and we are reducing the fracture by closed method, and I can see how the fracture is being reduced on these monitors over here. I can see how it is being reduced. I can confirm that, and I'm making a incision here proximally, and I will try to pass the rod. You can see I'm passing the rod here. As I'm passing the rod, I am confirming that it is going properly and the fracture is being reduced properly. And this is the end image of the procedure where I have successfully passed the rod through the fracture with an incision here proximally without opening the fracture site. Okay, so this is the pre-op or pre-operative image, and this is the post-op or the post-operative image where the incision is over here, and this is a closed reduction internal fixation with intramedullary interlocking nail or rod. And since it's interlocking, we are putting this screws here to interlock, preventing its rotation. Alright, so that is what it is. Now what is the treatment or the best treatment of shaft of radius fracture or shaft of ulna fracture? Remember, shaft of radius, shaft of ulna is an extra-articular fracture. So you can go for POP, closed reduction POP, but if you want the best treatment, you will go for open reduction internal fixation with plates. So again, look at this. This is a shaft of ulna and we are plating it here. So again, I'm showing an X-ray here of shaft of radius and ulna fracture, nicely plated with open reduction internal fixation with plates. Okay, are you understanding the algorithm here? Now let me quickly test you a small quiz and see if your remembering understanding is clear or not. What is the treatment of proximal humerus intra-articular fracture? Proximal humerus intra-articular fracture, open reduction internal fixation with plates. Very good. Distal humerus intra-articular fracture, open reduction internal fixation with plates. Very good. Distal radius intra-articular fracture, ORIF with plates. Distal femur intra-articular, ORIF with plates. Proximal tibia intra-articular, ORIF with plates. Distal tibia intra-articular, ORIF with plates. Shaft of humerus, ORIF with plate. Shaft of radius, ORIF with plate. Shaft of ulna, ORIF with plate. Shaft of femur, CRIF with nails or rods. Shaft of tibia, CRIF with nails or rods. Okay? So far so good, clear understanding. So these are most of the fractures that you will come across. These are the long bone fractures that you have to read and that will come across on your day-to-day practice. But remember, there are two places I have not talked about still. The hip fractures, we will discuss that in great detail in lower limb trauma, and supracondylar humerus fracture we'll discuss in great detail in the upper limb elbow fractures. So leaving those two, this is the general algorithm for almost all the fractures in your body. Now, apart from this, please remember that there is something called as Apart from this, please also remember there is something called as an avulsion fracture. Remember I told you avulsion fracture is when the muscle contracts, the tendons cause the fracture of the bone. Okay. Now, one typical example is your patella fracture. It's an avulsion fracture. Quadriceps tendon is contracted, and when it's contracted, the fracture fragment is pulled away. So in such fracture where there is a strong muscular force acting on the fragment, pulling it away, this will not reduce easily. And even if it does reduce easily, there'll always be this constant force pulling it away, which will not allow it to heal. So you will need a special device in such fractures. And this device will convert the destructive or the tension forces into compressive forces. So look at this. This is a fracture of the patella, and the fracture fragment is being pulled strongly and violently by quadriceps tendon. You would want a special device that converts these destructive forces into compressive forces. So what are those devices? The device is tension band wiring. Tension band wiring. Okay, this is known as tension band wiring. How do you place it? You do open reduction, internal fixation, and tension band wiring. So wherever there is a strong muscular violence, you will use tension band wiring. One example is patella. Another example is olecranon. Which muscle comes and inserts at olecranon? Triceps, right? So because of this fracture, triceps will pull this fragment away. You'd want to convert the destructive forces into compressive forces. So you will use tension band wiring. So that is the general algorithm of the management of almost any fracture in your body.